think we're recording. Perfect.
Well, he's gonna ask him to tell him that we had the question.
You guys can see my screen, the PowerPoint here.
Not all of them.
Perfect. All right. All right. So just please remember to mute yourself unless you're going to jump in. Feel free to jump in at any time that you'd like to discuss. It doesn't have to necessarily be in the discussion sections. And then please introduce yourself. Just be like, hey, this is so-and-so from wherever you're coming from. And then please jump in on the discussions. That's definitely what we're looking for here. So we want to acknowledge that we created basically our presentation and the outline for this presentation based off this editorial article by Lauren Erickson and Mark Sherry. This is just a great editorial for just an outline and serving as an outline for hamstring injuries. So the first question we want to tackle throughout this is what entails your clinical exam and how do you differentiate various hamstring and posterior thigh injuries? So the first possible diagnosis that we'll talk about is hamstring tendon avulsions. So first you're going to have an audible pop, or that's something that the patient might report to you, and you're going to have an immediate loss of function. So these folks will have difficulty with performing a prone leg curl, fully extending the knee and bearing weight on that involved side, as well as significant gait abnormality. Acutely significant ecchymosis and a large hematoma is usually seen during these. As well as potentially having just a Popeyes-based deformity. So like when you have a biceps avulsion, they call that a Popeyes deformity, and it's just that bulge of a muscle. You may have that in this case as well. This is clinically examined by a positive bowstring sign, as you can see on the right here. So what you'd be doing is palpating those distal insertions of the hamstring and then putting them to extension and seeing if there's extension on that as well. But MRI does serve as the gold standard for these for diagnosis. So if you're unsure, MRI to roll in or roll out. Next thing we'll talk about is apophyseal avulsions. You'd have an audible pop, deep achy pain, especially with sitting. Clinical exam is going to reveal ischial tenderness, pain and weakness with strength testing of the hamstrings and glutes, and pain with active and passive extension of the knee. Length or flexibility testing the hamstrings may actually reveal no deficit due to the loss of the hamstring origin point of anchor. So when you're taking them up, if they're not lacking any range of motion compared to the other uninvolved side, it might be because that bony piece is simply just dislocated from the ischiotuberosity, and so they're able to fully move through that range of motion without significant pain. An anterior posterior radiograph of the pelvis, as you can see here, may be useful in for definitive diagnosis on these as well. And you can see that avulsion just hanging there where that origin point would be. Next thing would be a proximal hamstring tendinopathy. I think the biggest thing for dispelling these and teasing these out would be origin. You're not going to see these acutely. Nobody comes off the field necessarily in acute because they induced a tendinopathy. This is going to be gradual onset of pain. Pain is going to be more localized in the proximal hamstring region, and that's going to be experienced with activity when sitting on firm surfaces or with prolonged sitting. Back when I worked in outpatient orthopedics, I would see this a lot, I think, with desk workers, people that were working in finance that were sitting for 12, 13 hours a day and weren't relieving that tendon and just pushing down on that on your sit bones, those ischiotuberosities. Most athletes, though, are going to display that tenderness, the palpation along the ischiotube. You're going to have local discomfort with minimal to no weakness of the hamstring and glutes, and local discomfort with flexibility testing with no limitations in hamstring length. So just another way to really tease out these between a hamstring strain. There are several specific tests for rolling these and rolling them out. Dr. Ahmad out of Columbia University wrote a paper on this, and that was the one that Erickson cited in her paper that we're reviewing here. The first one is the Perian Arava test, probably mispronouncing that first word wrong. So this test is performed by an active stretch of the hamstrings with the patient in standing. The hip is flexed to 90 degrees, the knee is then fully actively extended, and the heel is held on a support as they go through and extend that knee. For me, I think myself, the way I would perform this is have the athlete go into, be standing like beside a table or a stool or something like that, have them go into like 110, 120 degrees of hip flexion, put their foot on the surface, and then maybe back away and extend that knee. I think how they're doing it would be pretty aggressive if this is like more of a tendonitis or more of a reactive tendinopathy, something that might set off their symptoms a little bit more. So what I would actually probably go to if I was trying to really tease in between a hamstring strain and a tendinopathy would be this test, which is the bent knee stretch test. For this, the hip and the knee of the symptomatic extremity are maximally flexed, and then the knee is slowly passively extended by the examiner. So the idea with this is that you're having that proximal hamstring tendon, you're wrapping it around the undersurface and potentially the anterior surface of the ischiotuberosity and loading that tissue up to determine if it's the reactive tissue or not. And I think this would be the best test to go to for trying to distinguish between hamstring strain as well as a tendinopathy. Another modified version of this is the bent knee test. The biggest difference with this is it's a rapid lengthening of that hamstring. I just think that that would be hard to distinguish between having a hamstring strain and a tendinopathy. It might be something if you're trying to rule in more of a chronic tendinosis, tendinopathy type issue, trying to rule that in. I think this would be a good one to do. And you're always looking at where their location is. Is it right along the ischial tube, or is that pain shooting through like their distal thigh? And that might be more of a hamstring or sciatic nerve or some type of irritation. All three of these tests show good validity basically for identifying hamstring tendinopathies and strains. It is hard to tease out, and that would be my anecdotal way of doing it when I'm comparing the three tests. I wouldn't necessarily do all three tests, reserving the first and third ones more for, like I said, those non-reactive type of tendinopathy issues. And we have here on the right side just a good MRI showing some of the edema that you can see on the right side of the ischiotuberosity, as well as having a little bit of that signal coming through on that in the proximal hamstring tendon. With referred pain, these are the possible causes that might be originating at the lumbar spine that we need to dispel, and somebody that might be having more of a chronic posterior thigh complaint. Things that can be reproducing thigh pain would include piriformis syndrome, neurotension, a lumbar disc herniation, lumbar facet syndrome, which would cause nerve root compression, sacroiliac joint dysfunction, as well as spondylogenic lesions. And symptoms for these are going to typically include posterior thigh muscle cramping and tightness, numbness, tingling, shooting pain, those classic signs that we go to that I think ring a bell in my head when I'm doing my subjective interview. If I'm hearing numbness, tingling, shooting, I'm going to think radiculopathy to rule that in. Clinical exam is going to likely reveal a reduced range of motion of the lumbar spine, pain provocation with movement of the lumbar spine, tenderness and stiffness over the intervertebral or sacroiliac joints, a positive slump test, or a positive lumbar quadrant test. This is a study by Raymond that the Erickson article quoted, and I think it's a great way to look through. So for me, coming into putting on this presentation, I think my go-to for ruling out radicular pain would have been a quadrant test. Raymond showed in this paper that performing repeated extensions are very useful in either ruling in or ruling out. So seeing if they're reacting to that repeated extension as they move through motions, and if their pain is being either peripheralized or centralized. Next, we have the ruling out test for SI joint or piriformis syndrome. And they say that you can, Raymond in this paper says that you can rule out with cluster testing, Laslet's cluster. And then you can also potentially rule out piriformis pain by performing a FAIR test here. And you can notice the sensitivity being high as well for this test. So the FAIR test is distinguishable from the fader test. The fader test is typically performed in supine, and that's obviously going to be looking at FAI syndrome, where the fair test is going to be side lying on the uninvolved side and putting them into that flexion, adduction, and internal rotation of the involved side. And the other thing that you want to look at is looking at concordance sign. Is this where the pain is coming from? Is this reproducing that posterior thigh pain? If it's creating anterior groin pain, then maybe you do have an FAI, and that'd be something that you'd want to further work into your workup. So with that kind of brings us through the test. And big thank you to everybody who did go in and fill out the form that we had. There was quite a lot of responses. We were really happy to see that, and this was the results of that. As you can see here, the H test was mentioned quite a lot, and that's something that when I looked into it from looking at like that Askling article from 2014, it looks more like a return to play test. So is anybody doing a modified version of the Askling in acute or differential diagnosis at all, or is everybody basically reserving that for return to play? I can open that up to anybody now.
Hey, Ryan. I've primarily used the H test with return to play decisions. And I was introduced to that during my sports residency, and that's when I began using it with some of my athletes. So late stage return to sport.
Yeah. So I think we'll maybe cover that in the either the return to play or the later stage of the rehabilitation presentation that we might be doing in a week. But for those that don't know, it's a supine test where the person just actively straight leg raises, and you're looking at how much apprehension or how confident they are in performing that test. So maybe we can table that to when we're talking about the return to play stuff. But it's a great test, and I think it's something that it really teases into how the athlete feels and how confident they are in that feeling, from what I understand.
Ryan, I agree, man. I use that test a lot, and I even use it early on as well because I think it kind of shows our athletes kind of where they are, and then when you retest it, a few weeks later, they can see the improvement over time, so you get a little more buy-in that they're improving. Sometimes they perseverate over the idea that they're not playing, they're not getting better, and it still hurts. But then, hey, we did this test 3 weeks ago, and it's not as painful, not as irritable. So,
yeah, that makes sense to just give them like a litmus test of going through and being like, this is getting better. It's just like their way of testing them if they're getting better or not. That makes a lot of sense to be able to do it kind of in the early going, because they're going to self-limit themselves. I don't think anybody would just be supine 7 days, like post the maximal hamstring strain and really force themselves through that. So I think it would be useful if you maybe do it a little bit earlier than these articles mentioned. There is a single straight leg bridge test on here. Does anybody want to comment on that? It looks like it's a hold to fatigue. Does anybody have normative value or want to mention what the earliest they might do, and if that does any differential diagnosis testing at all? Or there's another thing on here, the handheld dynamometry at 0 supine, as well as seated edge of bed. Anyone can comment on that as well, if this is something that they're using for differential diagnosis or prognosis.
So for the handheld I can do my video. For the handheld at 0 and 90, I know that's something that they used in the Hickey articles. They used it for pain, and then also kind of like that return to sport, just so seeing where they're at those two different positions. So I guess early on, that's going to tell you more about how much is pain limiting them from generating their maximal force, and then return to sport would be closer to getting a strength measurement in terms of how close are they to the opposite side. Are they greater than 90? Are they at 100? And then the single leg bridge, that's something that I saw out of, I think they did it in an Australian football study. They used 30 reps, at least getting to 30 reps on both sides. I'm not sure if that's something that's realistic for some of these athletes, depending on what sport they play, but Again, that should be above 90% on each side. And I know that's something that they've used. So I'm not sure if anyone's used those ones before, but I've used Handheld a couple of times, and at least on initial eval, it's more pain limiting. They're not able to generate maximal force before their pain exceeds their tolerance.
Yeah. But maybe that's something you could use, like how Dan was saying, just you can give them that information maybe during the eval and be like, this is where your strength's at. This is, you know, the foot pounds that you're able to kick at. But now you're improving like 3 or 4 weeks out to give them some buy-in and just give them some confidence in their limbs. So maybe another, but thank you guys so much for these answers. This is part of what's going to hopefully generate discussion for us. With that, we can move on to that first discussion section here. So my question would be, and I specifically tried to find a video of an individual grabbing more of that glute area. So you'd have to kind of perform some differential. And I don't know if he unfortunately got up after this injury, was able to walk off, but let's say he did, he goes down, grabs his hamstring. He is a soccer player, so maybe he's being a little bit of dramatic to try to get a foul or something like that. And he comes over to your sideline. What would it look like for the order of your clinical exam on sidelines? And anybody can take that away right now.
Ryan's doing a presentation.
Hello?
Ryan's doing a presentation for 50 people here, so.
Hello?
Let's see how he's doing.
Bob, I think you're unmuted. I think that's
That's
Bob
fine.
Bruzga.
That's fine. If he steps in.
Okay. So I think my clinical exam would be, first of all, looking if they can walk or not. Do they not have a significant limp? If that's something, then maybe this isn't too much of a significant injury. Maybe it's just more of a acute muscle strain, maybe a piriformis injury, something that they can play through, like a moderate gluteal strain, or maybe they're cramping, maybe they're having some gluteal cramps, something like that. I think the first thing you look at is your functional test. Are they able to walk? If they're able to walk and they're confident in that, then you're going to rapidly go through and test them. Can they run? Can they cut? You know, do they feel safe and confident? What is the player, you know, talking? And when you're having these conversations, you know these athletes pretty well. They're still displaying their normal level of confidence in their limb and their abilities. So that's what I would start with. If they're not doing well and if they are in a lot of pain, I would start with palpation, having them go prone, palpating the ischial tuberosities, feeling if I can feel any deficits through there, going to like maybe of a straight leg raise, looking at a quick bowstring sign as we go through, just to see if there's anything that I might have to acutely mention to my orthopedic surgeon or physicians that we're working through, if this might be some type of surgical fixation case, if there is an avulsion. In the non-acute settings, obviously you'd be doing a little bit more specific range of motion testing, looking at the lumbar spine, looking at the knee, looking at the ankle. If you're seeing them in a clinical setting, it might be a little less acute. So trying to go through and just predict what their presentation is like, and really using some of the tests that I mentioned above to rule in or rule out. So with that, just the second question, is there any other differential tests that you guys commonly use in practice, or any paradigms that you would go through to kind of tease out these hamstring injuries or anything else? All right. I think there'll be more discussion on the second section, but I think that there are limited tests, so I think we hopefully hit a lot of them, and this will be useful for our group going on to use these. So with that, we're going to get into prognosis, which I think will be much more of a, hopefully a bigger discussion, and how to predict return to play timeline in order to inform the coaching staff and player. And this is something that when you work in high level athletics that you really need to balance and try to find a good feel for, and navigating these conversations, I think is really useful for trying to get to elite level athletics. So with that, a lot of these studies that detail prognosis and can kind of give insight for return to play timeline are MRI and sonography studies. So length and cross-sectional area of an injury are directly proportional to the time away away from injury, and that can be useful to predicting return to sports. So that is measured by having a greater amount of T2 hypertensity. And the way that they're doing this is they're really looking at the whole surface of this. They're looking at the length, the cross-sectional area, and looking at it as truly as in a box, and then also how that distance is away from the ischiotuberosity, which we'll detail a little bit more as we go in here. They did note that abnormalities appeared sooner on MRI than sonography, and that the MRI detected a greater amount of abnormalities, and that those abnormalities would fade a little bit faster on sonography versus MRI, just thinking that MRI is typically going to be a little bit more sensitive, but then you also have the cost balance with that as well. And so this study I thought was really useful if you do have access to an MRI and one of your athletes does have that. It showed that the longitudinal length of muscle injury on an MRI and the abnormal area as measured by cross-section on a sonography are useful predictors for the time to return. So what you can see from this graph here below, let me just move my Zoom people down, is that they measured that longitudinal area by millimeters starting from 0 all the way up to 250, and then they had the return to play or return to competition days down below here. And you can see typically more of the individuals that were in that 50 to 100 group were returning to play typically at that 8 to 20 time, versus if you're more up here in the 200s and 150, you're going to take longer time to return. So that would be useful, something that you can look at if your athletes do have an MRI. Various clinical criteria when assessed within the first 5 days of initial injury have been associated with a long recovery time to sport greater than 40 days. These are all things that anybody could do at a high school level or amateur athlete level, just to cue in and teach your patients when they could expect to potentially go back to their sport. An initial visual analog scale, pain of greater than 6, cues you in that it might be greater than 40 days, pain during everyday activities for more than 3 days, popping sound during the time of injury, any bruising, or greater than 15 degrees difference in passive straightening of the injured limb compared to the uninjured limb. That would be in a straight leg raise test. There's the time to walk test as well. This assesses an athlete's ability to walk with pain post-injury, and it's used to assess recovery time. Contact athletes taking more than 1 day to walk pain-free following injury were 4 times more likely to walk, 4 times more likely to take longer than 3 weeks to return to play than those that were walking pain-free within 1 day. This was a really good study of 165 elite athlete sprinters that went through, and they had an injury, a hamstring strain. It was their first time having a hamstring injury by their personal history, and they had a clinical evaluation 48 hours after the injuries. They found that athletes with greater active knee extension range of motion deficit required a longer time, and they compared that to the uninvolved side, comparing that to return to sport. So what they saw is with less than 10-degree deficit, and this was measured actively in a 90-90 position supine. Typical return to time was 6.9 days, and as you can see, there is a correlation that increases from 10 to 19 degrees, you were average out 12 degrees, and then from 20 to 9 degrees, it was 25.4, greater than 30 was 55.5. And I think it's really important to note that this wasn't a sprint group. We're going to detail a little bit the difference between a stretch injury, which typically takes a longer time to recur, and a sprinting injury, which typically is less time. And that has to do with the fact that it might be injury more to the muscle tissue versus the tendon as well. Next test is the resisted range of motion test. This can be used to assess an athlete's ability to resist knee extension at 90, 45, and 15 degrees of flexion in prone. So this is performed with an athletes that with recurrent hamstring deficits typically demonstrate significantly decreased knee flexion torque in the lengthen range, and that's going to be the 5 to 10 or the 5 to 25 degrees of knee flexion. So athletes typically demonstrate full isometric knee flexion at 90 degrees. So that's going to be their strongest point. And they found that athletes who have a significant weakness at that 90, 45, and 15 have a worse prognosis than those that have good force at that 90-degree position, that 90-degree position being mechanically advantageous to the hamstrings as they go through that motion. So the thought is that if you're weaker in greater ranges of motion, it's more dispersed injury, and if it's more dispersed, it's going to take longer to essentially heal. And then another factor that you can try to implement to predict return to play would be the palpation of the maximal point of tenderness. So that's going to be the more proximal site of the maximum pain to the ischial tuberosity, the longer time it's going to take to heal to pre-injury level. And this has to do with you're going to be more in tendon tissue the more proximal you go to that ischial tuberosity versus being down all the way in the muscle belly, as you can see in this picture. So this study was done. It was done 2 days after that initial injury. And they mentioned in this paper by Askling that there was a significant correlation between the location of the point of highest pain during palpation and time back to pre-injury level, and a tendency towards correlation at points 1 and so they went through at 2 and 4 or 2 and 21 days, and they noted this definite correlation that the lower down that they were from palpating the ischial tuberosity, the more likelihood that it would take that people were returning to sport at a greater rate versus individuals that were closer to that ischial tuberosity were taking longer, and that was measured at 12 and 21 days after the injury. I think the unfortunate part of this study is they didn't present the data. There was no graph or table demonstrating their data points. So unfortunately, while they noted that there's a correlation, and the study looked at a lot of things, it noted that there was correlation, but it didn't have those data points. So you couldn't go in and basically be like, all right, my athlete is maximal tenderness 1 inch away from the ischial tuberosity. What did those data points look like, and try to draw some correlations off that to look at how many days and predict that. So might be a good area for a future study to occur in. And like I said, this has to do with the construct of the tissue that's being injured. So as you get more towards the ischial tuberosity, you'll have more of that free tendon in space there. And then you would have that more of that intermuscular tendon where you're more likely to injure the tendon as well as the muscle tissue. And it's with the thought that potentially the more muscle tissue you have, the more that's able to regenerate more readily versus a tendon, which is going to take longer time to load, and it's going to recover from that. And then there's a few more articles that we felt that were just worthwhile mentioning. This was in contact sports. They found that hamstring injuries, once again, those sprinting type activities took less time to resolve versus like a stretching type injury. So I imagine this would be like your defensive lineman or an offensive lineman that might get pushed back, or it might be in an awkward bent over position that is forced into those extreme hip flexion moments. That's going to tax probably potentially more of the tendon, or have more wide spread dispersed injury to the tendon or muscle tissue. So that's just going to take longer to recover from versus a sprinting type activity, which might affect the muscle tissue. This was a really good longitudinal study in Gaelic football. They found that the typical time resulted was 26.0 days from sport, and they associated this with more proximal musculoskeletal junction involvement. So that finding of more proximity resulting in a worse diagnosis or prognosis has been repeated over numerous studies. Incited via match play, which makes sense because those are going to be more intense, potentially subjecting you to higher loads. When it's reoccurrence, when it's sustained in preseason and among players aged 25 to 29 years old, so maybe older individuals for that sport versus the younger 20-year-olds. From this study too, I thought this was definitely a good discussion point. At the time of injury, they surveyed these sports medicine physios, or these professionals, and and they asked them what they thought the intensity was based on their clinical exam. And so 62% of them thought the total injuries over this 8-year period were mild, 36 moderate, 2% severe. And that was based off of the scale, as you can see below here, from mild being 1 to 7 days, moderate being 8 to 28 days, and severe being greater than 28 days. So as you can see, they definitely underrated the amount of severe injuries when they looked back and they saw how long it took these athletes to get back. So a large proportion of the mild and moderate hamstring injuries result in more time lost than predicted. So maybe we're underdiagnosing how long it's going to take these individuals to get back to playing their high intensity sports. So with that, we'll open it up to the discussion section again. We're really good on time here, so hopefully, individuals can really detail what do they do first and foremost. What tests do they rely on for prediction of injury, or if there's anything that we didn't mention. And then I thought it would be worthwhile to talk about how we navigate these conversations with parents, coaches, to realizing that there is limited predictive validity in a lot of these tests. But at the same time, we do need to give coaches ideas of when their players are getting back. So with that, I'll open up to anything discussion-wise. We also, I think, have some chats too. So.
Ryan, I'd say that when there's you get into college and pro sports, like almost everybody's getting radiology right away. Players want to know, medical staff want to know, coaches want to know, everybody wants to know like every single detail that you can get as soon as possible. So if you can get the MRI right away, that's most likely going to happen. So the location of the tear, the size of the tear, the intensity of the pain, that's going to tell you a lot in terms of prognosis. And then when you get to the coach, I think it's going to be a lot of coach dependent. You're going to have some that kind of understand injuries and don't need a specific date. They just want to know a general time frame. Others want to know exactly when, and you have to decide, do you want to lowball it? Do you want to highball it? Do you want to try to be, you want to give a range anywhere from, a grade 1, 2 to 4 weeks, grade 2, 6 to 8 weeks, or do you want to give a broader, anywhere from 4 to 8 weeks and just kind of cover your butt in that regard. When it comes to talking with players and parents, I try to stay away from the general time frame. I'll give them a general one, but then I try to say, you need full strength, you need full motion, you need full flexibility, and you need full functional capacity. When that happens, that's when you're cleared. So that they don't fixate on, hey, it's 6 weeks, I'm not ready yet, or it's 6 weeks, I'm supposed to be playing right now, why aren't I? So I try to make it as functionally objective as possible.
Yeah, no, and I think that's useful. So it sounds like you go to the MRI a lot as far as predictive value.
Yeah, with the research you just presented, basically you're showing the more proximal, the larger the tear, et cetera. The longer, expect the longer duration. How much I communicate that to the player and coach, and it's dependent on who I'm talking to.
Yeah.
But in my head, I'm thinking like, all right, this is a pretty small tear. It's in the muscle belly. Like, I think I can be a little more aggressive in the situation. Or if I see a large tear in the tendon, I'm definitely going to be a lot more conservative.
Yeah. No, that's helpful. And I do think when you have access to that, it's probably the best thing from what the literature's pointing out to. I would love to see another, I think, a really good research opportunity, maybe not the hardest study to do would be trying to replicate that sprinting study of what that active range of motion and the typical return to timeline looked like in like a contact sport. I think would be really useful. Potentially give some type of differentiation for that. So, yeah. Any other comments of what people feel strongly in looking at, or, how they navigate that kind of minefield of talking to coaches, parents, anything that they specifically do at their level? How do you even write that in injury reports with return to play? What does like your group or team do?
Brian, I'll chime in and kind of piggyback on some of the discussions and conversations you've had thus far. This is Krista Willie from the University of Wisconsin-Madison. I just wanted to make a comment about MRIs and relying on imaging. I agree, we do often get MRIs, but one thing we have to be really careful about with imaging specifically is we know that the time from injury affects what that injury looks like on MRI. So that pattern of edema, that area of edema will certainly change the further out from injury they are, because we're talking about a lower extremity injury. In just because of gravity, we'll see that edema change quite a bit over time. So that's certainly one thing I try to be sensitive of, how far out from injury was that MRI taken. And there is some evidence, you presented some good articles that showed some correlations between MRI findings and return to play outcomes. But there are also some articles that also contradict that, showing that we can't just rely on MRIs to predict return to play. And I think one of the biggest issues that comes into play here is that return to play is not always the clinician's decision. It's, when you're working with those, I shouldn't say it's not only the clinician's decision. When you're working with those higher level athletes, return to play is often influenced by coaches. What's the schedule? Is there a big game on Saturday? Is that a starting player? So I think that's one limitation of some of those studies that we see too, is so much of that research is based on days to return to sport. And even though that could be helpful, maybe something more like a functional outcome or their strength at return to sport, or how their strength is progressing might be more appropriate. And I have a feeling we'll get into some of those discussions as we start talking about return to play testing and what criteria is or isn't used to help or make those decisions.
Yeah, I do think it's useful to, and what you're saying is you can't just rely on these MRI studies, especially when there is some conflicting evidence out there. And I do think it's useful to really give more of a target range versus being like, these are the studies that's showing the exact, return. As you can see from that scatter plot, though, it did show an association. It was completely all over the place too, as far as these data points. So,
yep. And I think there's something there. I think there's a story there, but I think when you're working with high level athletes, there's more to the story than just an image too. And we're actually at UW, and there's a couple other sites too that are trying to use some more novel imaging measures, both MRI and ultrasound, to try to actually assess muscle architecture and not just yes or no, is there edema. So like you've been saying, or like some of these studies show, if there's a complete disruption or if there is obvious deformity of the conjoint tendon, then that's probably not a very good prognosis. But a lot of the MRIs, you can't see architectural damage to that extent, but there's likely some architectural damage at the muscle fiber level. So trying to tease out exactly where or how much, there's information there, but with a standard clinical conventional T2 MRI, we might not be getting all the information or all pieces of the puzzle or parts of the story that we know are there.
Yeah, and I think it brings up a good point of, in that, there was a study done by Malopoulos, that's the 165 sprinter injuries. They did find that there was no correlation between established range of motion deficit or ultrasonographic appearance and a risk of re-injury. So, and there are a lot of studies out there, I know too, that show that just because the athlete is hitting those baseline objective measurements of strength, that they still have abnormality findings on the MRI as well. So I think that just kind of bodes to, you can't plant your flag just on MRI, and there's no magical algorithm, and we have to consider everything, how the athlete's presenting in front of us and what their subjective and functional information looks like.
Yep, for sure. I agree.
Yeah. Thank you.
Yeah.
I'm just looking through the group chat here. Yeah, and I don't know if anybody else wants to comment, but from my standpoint, it is that histological of the free tendon. Just that's typically going to be more tendon-based tissue versus more vascularized tissue, getting more into the mid-muscle belly of the hamstring. How much? And question from Aaron O'Connor here is: how much do you feel like history of a prior hamstring injury plays into your return to timeline and prognosis? I think that's a really hard, and there is a lot of information kind of coming out about that now, but a lot of the studies that we looked at for this presentation was first time hamstring injuries. But from my typical standpoint, it's a worse prognosis. It's harder to get back when individuals have these, and obviously they're more predisposed to another recurrent hamstring injury. I think there's a lot coming out with looking at like acute to chronic workload ratios and trying to make sure that individuals don't have a ramp up in the weeks preceding their return to play, and getting individuals back, which I think we can maybe delve into a little bit more with the return to play discussion too. Just kind of reading through the chat still. I think Fred said athletes with no limited history generally take longer return. Sprinter takes longer than like a golfer, which might be performing a little bit less of a random motion. And there's another article here, a combination of initial and follow-up PT examination. So I don't know if I came across this one. And maybe this is a lot of what you were saying, more so for just that you can't just rely on the MRI exclusively, I think. Anybody else have any questions or any comments on anything that we presented or any of their framework at all?
Hey Ryan, just hopped on. Looks like you did a good job out of attendance today. My question is, does anyone do baseline measurements of like either Nordboard or like how do they determine if an athlete strength-wise is ready to go back? Is it just looking at whether they do as kinetics or handheld dynamometers, current literature out there, or do they have baselines of their own athletes that they try to restore again?
Yeah, I know Duke does the Nordboard pre and postseason testing, as well as we've started to integrate the groin bar, which is obviously more your adductors and groin muscles. But yeah, we do use the Nordboard, which could potentially give you predictive value. There's a study there if you were comparing like acute strength, when you're maybe in the subacute phase and you're getting back into 3 or 4 weeks out, looking what their percent deficit is. So I don't know what other groups do.
Yeah, I'll compare it to the uninvolved side at the eval and use that kind of as their baseline. Just make sure they don't decondition too much and try to get to, close 90, 100% there.
And Tony, how are you measuring that?
We have an isokinetic dynamometer, so I'm using that. But before I had that, I would just use handheld dynamometer.
Does anybody use like the active range of motion test at all who might not have access to MRI, or their athletes typically don't get an MRI? Any outpatient therapists out there that have used that readily and found good results with that?
I haven't, but I know that I've seen some stuff talking about if you don't have access to an MRI or just money and stuff, just palpating the percent length of tenderness of the hamstring has been shown to be correlated to prognosis. So it's just basically like an MRI, but not an MRI. So similar to those studies, but they've done it just looking at length of the tenderness, basically.
Yeah.
I haven't seen that published anywhere, but I've seen like Brandon Schmidt talk about it before, and I've seen some poster presentations that refer to their data.
Yeah, that makes sense, looking at like a percentage base just versus like in a longitudinal length base, or performing those complex calculations that you would need for an MRI, even if you have that. So you might not have access to that as well. Yeah, anything else for prognosis or diagnosis? Anything other last kind of parting shots, I guess? that anybody
Hey,
wants.
Ryan, sorry, one last thing. So I saw on your slide, you included the one about clinicians who tried to predict the severity and time away based on the hamstrings. And you and I kind of talked about it, our thoughts on it, but how do we navigate educating patients and coaches on when they might be back? We've seen some people back as early as 2 weeks and do fine. And then we've had others who it turns into a chronic thing where they're out for up to like 5 months sometimes. What are your thoughts on that as far as educating on expectations?
Yeah, we had a little bit of a conversation, I think, before you jumped on that. But I think the biggest thing is just trying to give a range and not really just tease down to one date and say they're for sure going to be back. Just keeping it open, and then just not just focusing exclusively on the MRI if you have that. Just trying to basically tease in, these are good prognostic factors. These might be some prognostic factors that might take longer to recuperate from this injury. And I think part of that is your relationship with the athlete and understanding who they are, and is this a person who was extremely confident and then isn't confident? I think that's the type of experiential kind of learning that you undergo as this is just reading the situation, or is this somebody who is getting confidence in this? I think that can be really good for a prognostic factor of determining, when you're going to have those conversations with the coach. But I always err on the side of caution, always give that range. Like if I was pretty confident that I saw something that I thought it would get back in 6 weeks, I would say it's probably going to be 6 to 8 weeks. Just give yourself kind of a buffer. I would err on the side of caution.
Ryan, I like the point that you brought up with, it doesn't matter who you're talking to, but giving them the, like, hey, these are some good things that are in your favor, or these are some bad things that are not in the athlete's favor. But this might be the time to remember it. I'd say 99% of the time, this is the job of the head athletic trainer, not so much the physical therapist on the team. If you're in an organized sports setting, like this is the primary role for the head athletic trainer. So making sure to be on the same page with them is going to be crucial.
Yeah, absolutely. And just making sure they're not walking into a situation where, like in our teams at Duke, it's always the head athletic trainer that's communicating with the coaches, that, you're not setting your athletic trainer up for failure, and just giving them all of that information and let them take that and communicate with the coaches with who they should have a good relationship with.
Mm-hmm.
I think just reading the group chat here. I think, I know Dan recently just published an article in the International Journal of Sports PT on return to sprinting progressions, which I think will be huge for getting athletes back up to sprinting, which obviously is something that's really limited with these hamstring injuries. So that would be a good thing to definitely talk about. I think next week we're going to dive into how we rehabilitate these athletes and what are the steps and progressions that we like to look for. What are the loading things that we like to do? What are our go-to exercises? That'll be a really good, I think, presentation. And then after that, we're going to talk more about return to play and navigating that. So maybe more of that sprint progression during then. I'm trying to get more of this discussion. Does anybody else have any thoughts on navigating this area at all, or any feedback at all?
I just had a quick anecdotal case. I treated a young competitive fencer. On her lead leg, she had a stretch hamstring injury, but it was interesting because she had started fencing at such an early age. Her lead leg was actually stronger than her unaffected side, even though it had pain. And then because I'm an outpatient, I'm Jessica, by the way, I'm a Los Gatos Orthopedic Sports Therapy sports resident. We're private practice. And so they didn't get an MRI. I didn't see her till 2-ish weeks, I think, after she initially injured it. But it sounds like she was walking okay. But it was just interesting that on initial eval, we did handheld dynamometry strength testing, and her numbers were all higher on the injured leg with pain. But that was just, it was like hard for me to determine, you know, what strength number do I have to get her back to? Obviously strength testing without pain, but just keeping in mind like the sport demands for that type of athlete, right? Like obviously her lead leg is going to be stronger. So.
Yeah. And I think that goes just, you can't just count on one thing. Like they're still having pain, even though they're strong as they need to be. Was she lacking any muscle length for that case? Like was her straight leg raise different?
Yeah, she did have the muscle length deficit, so I had that as a objective value.
That would be interesting because I was fortunate enough to work my first fencing meet like a month and a half ago. It's a crazy sport. It's really cool. And what I noticed is that they were almost like pushing off like a baseball pitcher would on their rear leg as they deliver. But they tend to like go into almost like a split, like a hyper hip flexion while keeping that knee straight. So I just wonder if she was just so frequently eccentrically loaded that resulted in just having that really strong hamstring compared to the uninvolved side. And I would think anecdotally again that she would have more range of motion on that lead leg versus the other one. So to have a deficit, that would be something that would be huge to work on, I think. Yeah. But good case, thank you. Anybody have any other cases that they'd like to talk about or any sticky situations that they've navigated?
I'll add real quick, Ryan, I haven't heard anybody mention it, but I think nerve glides are a huge, huge adjunct to treatment in this population. Not only in the chronic cases like the proximal hamstring tendinopathies and stuff, but even in these hamstring injuries, I think they have to be an integral part of the process. And it's kind of one of those things that, you know, athletes love numbers, they love comparison, they love to see improvement and that over time, and that's one of those ones where they compare right to left side and they can kind of feel that it's still different. So again, you get that buy-in, you know, that, you know, we want you back at your to be top shelf. And obviously, if this feels a little bit different at this time, again, you're middle of the season, you know, major game coming up, it might not be perfect, but, you know, we want to get you as close as possible, but it's something objective that they can feel that is a definite part of this process.
Yeah.
Point, sidebar, there was an article in AJSM, it's old now. I'm trying to think of it. I think they were Finnish authors, but it's called Muscle Injuries, Biology and Treatment, AJSM. It's probably a 15-year-old article by now. I mean, it's old. But if you don't have that one in your library, I'd really encourage everybody to read that one because it talks at the cellular level about what's going on after muscle injuries. And I could send it. You know what I'll do? I have it. I'll send it to you, and then you can share it with the group.
Sure.
Some of it's on rat studies and all that other stuff, but it's all we have. But there's just some good pointers, like the initial phases of injury, what you should and shouldn't do because of what's going on at the cellular level. So I'll share that with everybody. This is a side note.
Yeah, that'd be a good read before next session, and we can discuss, you know, I think like looking forward to next week, just definitely going in and seeing how long we're keeping these athletes not moving into those lengthened positions of knee extension and hip flexion. And I think it'll be a really good conversation to see what we're all doing and bringing that all together.
And Vian, your mustache is fantastic.
Oh, you can see this baby from here? Niles is shaking his head. He disagrees, but I appreciate
glorious.
That. Can you see it still from here? It's gone, huh? That's all right. I appreciate that.
It is glorious.
You still see it from far away.
Just the lighting, man.
I'll take what I can get.
I just wanted to kind of echo what Rich was saying there as well, as far as working with the athletic trainers, especially on predictive value. From our discussions, sorry, I'm Niles with Wake Forest, if you don't know me, but our discussions with our athletic trainers, we typically will hold off on the prognosis at least for a day or two to look at some of the other factors, like you talked about, like those early prognostic factors clinically, before we say, oh, you know, it's a hamstring, and here's how long we're thinking with this person. We will sit and have those discussions and really kind of see how they're doing the next. We always kind of make a decision on what our timeline is in that first week on what we're thinking. Obviously, they're shut down for the first week either way, so we're kind of looking at that. So I would just kind of echo that, working real well with your athletic trainers, because they're the ones who are dealing with us on the front line level.
Yeah. Yeah. I don't, yeah, to your point, I think it wouldn't be beneficial for anybody to, like, after the game's over, to just, give coaching a standpoint. Those are maybe more of your, if you're looking for like a college football standpoint, maybe that conversation happens more in the injury update on like Monday or Tuesday versus like even Sunday acutely after, and give yourself more time to really gather the whole picture, as we've said.
Hey, Ryan.
Yep.
I know you're, this is Kerry Molinex at Duke. I know you're running kind of short on time. There's been a couple comments as to injections and some of the use of either biologics or just injections. So don't know if you want to dive into that now, or just something to think about next time. Speaking of old papers, and Dan, there is an old, I think 2000 was the published date by Mormon and Levine with an NFL study, admittedly biased, as Dr. Mormon was the team physician here after that, and but relied on that study to kind of justify doing injections within a certain area of the hamstring. And so if you look at that study, I'll send that to you. You can send it out as well. Basically mid-muscle belly, if there's a defect, pain, that type of thing, of an early injection to reduce return to play time. And we've used that quite a bit over the years, and with overall very, very good success rate. And so just something to think about maybe for next time to dive into.
Is that something where you would look at the MRI, or like what would rule in an athlete for injection versus maybe if it's mild or not? Like would you plant your flag on for that?
Yeah, so based on that study and really our experience, it was not MRI based. It's location based, location palpation. They've got a criteria based on what zone it's in. This 2B zone, which basically is mid belly, and a palpable defect or a palpable. You may get a defect, you may get a hardening there on palpation. So it's really based on that. Often done day of or day after injury, and so yeah.
Yeah, thank you. I think that's really good to kind of clue into whether you would be doing those injections or not, or at least pushing for them and trying to support your findings with your doctor.
Yeah, obviously, area of controversy, and as well it probably should be, but I think, but also a good area of potential discussion.
Yeah, absolutely.
Piggybacking that, Kerry, I'm curious what the group is doing when in the trenches. Are you guys still doing NSAIDs? It used to be just you got an NSAID and a bag of ice. Going to go back in the day. I mean, have you guys found trends that you're going away from that, maybe going more for a painkiller, or do you still find that you're well, I'm sure they're probably asking for things like ibuprofen, but you're actually doing that? Just curious what you guys are doing right now.
If that was for me,
that's anybody in the trenches. Yeah, Lee, Kerry, Ryan.
I see Niles pointing
Niles, what are you guys doing?
So I think, yeah, there's still a propensity for NSAIDs with that muscle injury. Again, we have some, like most out there, I think probably different physicians for different sports. And so you get some, even in the same institution, you'll get some disagreement about that, which always makes it challenging for the rest of us as to counseling our athletes, and especially those of us who work with multiple sports, right? And so, but the short answer is yes, that's being done. The NSAIDs now, it's not, obviously it's not just that. There's a lot of treatment involved as well. of various kinds. And I think that's one thing I'm sure to dive into as we continue this. This is a great discussion, something, good job, you guys. It's something that you can spend an awful lot of time on, and people are, but I think it's well worth it.
I got one more. Now that Voltaren patches, or the gel, excuse me, is over the counter, do you find yourself using that more now too? Anybody?
I may be different than most, and maybe I'm not doing enough research, but we tend to stay away from NSAIDs or anti-inflammatories in that initial at least 2 or 3 days, almost as allowing that inflammatory process to happen and for the positive effects that come out of that. But again, we will, as Carrie alluded to, the issue is you have 6 different team docs all throwing in their opinion, primary care, orthopedics, and then we have athletic trainers that have their opinions as well. And so it's a little bit difficult to say as a system-wide level, this is what we do. But at our recommendation, we're trying to avoid it early on, and then maybe in that after the first 3 to 5 days, then working it if they're still having some pain and swelling and that kind of issue. And then maybe doing a little bit more ice, but really kind of working that direction. And that's the same with the Voltaren now as well.
Yeah, I think my view aligns with Niall's. Just like I feel like you want that scar tissue formation, though it's that we know that tissue histologically is not going to be as good as a native tissue that's being laid down. But I think in that first week you want that formation because you do have to compose like the matrix to bring back strength, and it does change the muscle length tension relationship where individuals are able to generate force at a different muscle length. And it is going to alter things, and it's never going to be as good as it was. But I think that's better than just having an innately potentially weak muscle tendinous junction structure. So I would probably stay away again from the NSAIDs in the first week or so.
My experience has been the same with Niles. It's just such a mixed bag with different doctors, different PTs, athletic trainers. And one of the biggest problems is that a lot of these athletes think that like ibuprofen is this magical pill that takes away swelling. Like if I have pain, if I have swelling, if I have any inflammation, ibuprofen is this pill that takes it all away. So I should have 100 milligrams every day. And that's what they're asking for. And sometimes you see like some people, they say, no, this isn't appropriate for all the reasons you guys just mentioned. Let's stick with Tylenol for the pain. And then the next day they talk to a different staff member and they're like, oh yeah, here you go. Here's your pills. So it's tough. Let's try to get any consistency with that.
Yeah. And I think that's where you're just trying to have those conversations, preseason, like this is our policy, establish something, try to get everybody on board and have a good debate with them. Voltaren, from hockey experience, I know Voltaren cream was available in Canada before it was available here, and people live and die by that, over the border. So.
Those have not been used yet. Yeah. So yeah.
Right. Any parting thoughts from the group, though? Thanks for the discussion. I was really happy with how we got more into that versus just presentation mode, and I think that'll be huge for everybody on here. Thank you, everybody, for coming on and participating. This has been a great reaction. We're going to go back to 8:30 next Friday, just to try to get as most people on as we can. We'll continue to record the sessions and post them on YouTube if you're not able to make it. And we'll do the same format where we're going to construct an outline, hopefully have that to you guys by Monday. Would appreciate any insight based on the forms, and then we'll send you guys the presentation and the Zoom link on Thursday, the night before, and we'll see you guys at 8:30 next Friday. All right. Thanks, everybody.
Thanks, Ryan. Good job. See y'all.
Nice job, Ryan.
Yeah. Thanks for coming on. Thanks, Dan. Appreciate everybody's insight. Carrie.
Big discussion.
Yeah, it was good.
So it looks like you breezed through your presentation in about, what, half hour?
It did go quick. Yeah, and that was good. And I thought I'd actually get to 40, but just kind of went fast.
Yeah, looks like this format's a good idea, though.